afternoon, on where you are joining us from. I just wanted to take a moment and say thank you for attending what's now our third Performing Arts panel. Tonight's topic is going to be neuropathic pain in the performing arts population. This meeting is being recorded, so if you have colleagues that aren't able to attend, please let them know, or if you'd like to reference anything in the future, it will be recorded. There will be an email that will come out from the AOPT, which we can then pass along to those that RSVP'd and weren't able to attend. So just to let you know, I am Melissa Strzelinski. I'm the current Vice President and Education Chair of the Performing Arts Special Interest Group. I'm excited to welcome our presenters tonight, who are our experts on neuropathic pain in the performing arts. They have asked that this really be more of an informal panel so that questions could get answered. They do have some background material prepared to get us all on the same page with how we're talking about pain. So our format will really be introduction of the speakers. We'll get a background on pain. Then we'll kind of dive into the questions that were submitted. And then time permitting, if there are additional questions that come up, please let us know. You can always put questions in the chat if something comes up, and perhaps the speakers can follow up if there's not time to get through everything tonight. So to give our presenters the time they deserve to get through this, I will hand it over to Mike Costello.
Thank you, Melissa. I appreciate this. Welcome, everyone. My name is Mike Costello. I'm an associate professor of physical therapy at Ithaca College. And there I run, for lack of a better word, the Performing Arts Wellness Initiative, including walk-in clinics and workshops for performers on our campus. How about Monique next?
Hi, I'm Monique. I'm a physical therapist with Johns Hopkins. I am a former fellow in performing arts physical therapy, and now I work at Hopkins as part of our performing arts team and seeing dancers, musicians, figure skaters, the whole performing arts kind of realm, anywhere from adolescents to adults. And I'm excited to be here.
And my name is Andrew Kunin. I'm a physical therapist. I'm also at Johns Hopkins. I treat a lot of orthopedics. My specialty is chronic pain, but I treat quite a bit of neuropathic pain and musicians, including some of the musicians over at our Peabody clinic.
Great, thank you. So I believe Mike will start with just a background into neuropathic pain.
Yeah, so let's see if I can share my screen. I'll share the correct screen. Oh, that's it. Sorry, I'm a little ahead. So everyone should be able to see a PowerPoint here. Sorry to have to use PowerPoint, everyone. Yeah, so this is Ithaca College's orchestra. Seen a number of these individuals. So just a brief background. So certainly we know that performers in general end up with lots of problems that make performing difficult. We're going to have at least somewhat of a focus for this talk on musicians. So we know that the performance-related musculoskeletal disorders in musicians is remarkably high. Most commonly, those types of conditions are in the upper extremity. And we at least believe strongly that recognizing pain mechanisms within those patterns will help clinicians best manage these performers. Neuropathic pain while there's actually not great literature looking at the frequency specifically of neuropathic pain in performers, there is some evidence here. So some studies have, the frequency has been reported as being very wide. one study looking at a specialty clinic working with performing artists estimated the range of neuropathic pain to be between 4 and 48%. If you see something that wide, it means we probably really don't know very well exactly how frequently this is. And maybe we're not recognizing it as well. We do see that things like carpal tunnel syndrome specifically may range from, you see it here, as much as 20 to 36% in instrumental positions, in instrumental musicians. And also that this interesting study comparing bowed in-string instrumentalists, so violinists, violists, bass players, etc., were more likely to demonstrate signs consistent with neurogenic thoracic outlet compared to individuals in a control group. So let's briefly talk about what we mean by these different pain mechanisms. I'll just add, I'm old enough that this was when I graduated from PT school, this wasn't even really a thing. So our knowledge in this area and this paradigm of thinking has really exploded in the last 2 decades. So generally, we can think of nociceptive pain, neuropathic pain, and nociplastic pain. You can read the definitions here from the International Association for the Study of Pain. When I explain this to patients, I might simply say that nociceptive pain is the pain that we commonly think of that's more directly associated with the issues in our tissues. Neuropathic pain is nerve pain, which may seem a little bit like redundant, but that's pain arising from the nerve tissue itself. We can think about neuropathic pain further divided into peripheral neuropathic pain and central neuropathic pain. I do want to be clear that for most of the things that we're talking about today, we're really referring to peripheral neuropathic pain. And then nociplastic pain, this is pain due to a variety of different processes within the processing system of how the input is interpreted that might augment how anyone perceives pain. Sort of like a combination of software and hardware changes is some language that I might use to explain this with patients. To help us better recognize how these might present and help us recognize them, there's things common in the physical exam and subjective exam. So there's recently a Delphi study that was published interviewing a wide range of international experts to help to delineate what we think is most important to help us identify these things. So we see here that nociceptive pain, that pain most associated directly with tissues, is that we would expect this pain to get, if there's an inflammation problem, which is common in many types of acute pain, that if you give them something to control their inflammation, they do better. Their pain is predictable. We know that tissues heal, so they're going to hurt more at the beginning, and as those tissues heal, their pain is going to resolve in line with that tissue healing. We would also expect it to hurt where we think the tissue problem is and not hurt where the tissue problem isn't. So that's where we would not see generalized hypersensitivity. Generalized hypersensitivity might be more likely in patients with nociplastic pain. If you load the tissue that you think is the problem, it hurts more, and if you unload it, it's likely to hurt less. So it might be provoked by specific movements, and is less likely to be responsive to things like antidepressants or anticonvulsants. So whether that's things like Lexapro or gabapentin, those things might be less helpful for the patients. The physical exam, honestly, I tell my young students, the physical exam makes sense. They have those signs of acute inflammation. If you poke at it more, it hurts more. If you poke at it less, it hurts less. The testing is consistent. The mechanical pattern makes sense. And quite frankly, if all of our patients were like this, our jobs would be a whole lot easier. Neuropathic pain is the distribution, especially peripheral neuropathic pain. We would expect their symptoms to be what we would think of anatomically. So is that in a nerve root distribution or a peripheral nerve distribution? Maybe they have specific evidence of a specific nerve injury. They had a laceration and a particular nerve was cut, for example. They have a nerve conduction test that can tell us very clearly that there is an impairment in this nerve pathway at this specific place. It sounds nervy. It's electric-like, shocking, nerve numbness and tingling, maybe even some crawly sensations, some prickly. This is the nature of these symptoms are different than the other categories. And while we can provoke it possibly more consistently, the movements that provoke it are more specific to compressing and or tensioning the nerve in question. And that's really where the physical exam comes in. So your physical exam, you might have changes in sensation that are along that peripheral or nerve root distribution. Again, techniques to provoke the nerve itself, whether that is something like a Phelan's test, a Sperling's test, or an upper limb neurodynamic test or upper limb tension test, depending on which language you want to use to describe that, would be provocative. People with nerve pain may present with both decreased sensation, so numbness or lack of pain, hypoalgesia. They can also present sometimes with increased sensitivity, but that increased sensitivity tends to be localized to that nerve pathway. We may also see changes in deep tendon reflexes, and we may also see muscle strength performance changes, again, specific to that nerve pathway. For nociplastic pain, oftentimes this problem is more widespread, poorly localized, oftentimes multiple other conditions around this. So things ranging from fatigue, memory loss, concentration difficulties, sleep deprivation is a big one, is associated with cognitive and affective tendencies. So mood disturbances is a big part of that. These patients oftentimes don't respond as well to NSAIDs, not responsive, less responsive to surgery because there's not a specific tissue to go after. The pain is oftentimes in multiple body regions and actually may spread. It might be very common to see the person say, my pain started here and then it's kind of moved up my arm, or now the other arm hurts. Oftentimes, these patients have a history of failed interventions, and part of that may be because previous practitioners may not have recognized this well. The other reason is that this condition is just more difficult to treat. One thing from the subjective exam that may help you, or a questionnaire, is the central sensitization inventory, which is a specific inventory that's been designed to help clinicians identify patients who are likely to have this as a relevant component of their condition. The physical exam, quite frankly, oftentimes doesn't make sense. It's sort of the opposite of nociceptive pain. Whereas in nociceptive pain, if you load the thing you think is a problem, it hurts more, and you unload it, it hurts less. In nociplastic pain, that direct kind of mechanical relationship is oftentimes no longer present, or certainly no longer consistent. If you've ever heard the patient, hey, when I think about it, it hurts, that's not just a saying. That may actually be true for them. Oftentimes the findings are inconsistent, mechanical. You do a very gentle test and you really flare them up. So the proportion of response is oftentimes doesn't match the mechanical loading. So we just wanted to give people this general overview of what many experts perceive to be important hallmark conditions here. that's what we wanted to give for that brief background. So I'm going to come out of this.
Great, thank you for that background, Mike. So then we'll dive into kind of the framework of questions that were submitted in advance. So if you can speak to, now that we have an understanding of our different types of pain, how is addressing neuropathic pain in performers different than how we address it in our non-performer patients? And I would say you could speak freely of nociceptive, of all the pain types that you just outlined.
I just talked for a while, so I'm going to let Andrew and Monique.
All right, so I'll take this one away. So I think that it's important to remember, especially with performing artists, especially musicians, they may not want to talk about their pain as much too. I think that's important to understand. I think there's a kind of a fear associated with being aware of their pain and how that may take them out of like playing, performing. So that's an important consideration. The other thing to consider is that a lot of our performing arts do tend to have a little bit more of hypermobility, tends to be a common thing that we see in a lot of our musicians. So when you're treating neuropathic pain, not only treating it, but also examining it, you want to make sure that you are considering their hypermobility. And when you're doing things like upper limb tension testing, you're making sure you're getting to the end range to really bring on those symptoms so that you're not missing it, right? So they could potentially be hypermobile. They may have neuropathic pain, and you think, oh, I did this upper limb tension test, quote unquote, the standard way, and it didn't elicit any of their symptoms, right? But if they have that hypermobility, you have to make sure, let's say, if they have a lot of external rotation, going to their full external rotation and then really extending them out to bring on those symptoms. And it's important to make sure that you're not just bringing on the symptoms, but asking, is that the same symptoms that you're complaining of, right? To make sure you're identifying that. So I think being aware of their hypermobility, also being aware of what are their demands as a musician, right? So what instrument are they playing? There's certain instruments that may make them more susceptible to different type of nerve involvement, right? Just based on positional, like if they are, let's say, a flautist, right? And they're kind of twisting here, or violinist. So looking at their posture, looking at how they're playing, because the other thing that's important to consider is that every musician has their own kind of unique playing style, right? You could take two violinists and they could play completely differently. Their sound may sound the same, but their actual posture and playing, the way they play, could be completely different. So I think those are important kind of clinical pearls to think about when you're treating a performing artist, to make sure that we're capturing everything.
I think the only thing I would add to that, because I think that's perfect, everything you said. The only thing I would add to that is sometimes it can be challenging to modify what they're doing. You know, with some folks in a different population, if most of their symptoms are, let's say, typing in the computer, ergonomic changes and the way that they do it might be a little bit easier to achieve. Somebody's been playing a certain way for 20, 30 more years, it may be a little bit more challenging to modify some of those things, because if they play at a really high level, and that can be a challenge. And I've run into some of that where it's been difficult to change some of the load that they're having on the nervous system, and they really can't, you know, they have to play at a certain speed and a certain complexity. It may be very difficult to now modify some of that after decades of time.
Yeah, and then the only other thing that I would add would be specific to neuropathic pain in performers is that playing off that idea of fear. So we see generally sometimes performers may be reluctant to admit that they have a problem, depending on the culture of the place that they're working in. But I think, at least my personal experience with musicians is if you say the word, you have a nerve problem, like I see many musicians in particular automatically assume that that's worse, and that's sort of like a death sentence for them. So while I think it's important that we're upfront and transparent with our patients, as I'm doing any sort of nerve testing, and that might be positive, I'm very quick to make attempts at least to reassure the patient that just because I think you have a nerve problem doesn't mean it's a worse problem. And in fact, it's important that we recognize that this is a component of the treatment. And the good news is there's lots of things that we can do to help this problem. And especially for a musician who maybe has sought out treatment for and hasn't been successful, sometimes finding that neuropathic component may be an important missing link.
So I just thought of one last thing, is that remembering what treatment you're doing and timing with their performance. I'll give you an example. I had a soloist pianist who was going to go on tour, and when he had a lot of neck tension, and we did some dry needling, and he felt much better in terms of his symptoms. But when he practiced later that afternoon, he felt like he could play to speed. So he was utilizing some of that tension to actually create that. So especially if he's about to perform, game time treatment may be different than off time treatment because of some of the demands he had. So he wouldn't want to do that treatment during that time if he had to play.
I think that was great. You guys covered all the way from kind of the framework of the language and how we assess and care for these performers, all the way up into Andrew's thought on the actual implementation of treatment and its role in performance. Kind of continuing on this realm, Mike touched on using the word nerve itself can heighten the anxiety or fear surrounding it. So one of the questions was, are there any specific performers that tend to have more severe cases of neuropathic pain?
So I'll jump in and start here. I wouldn't say, so as far as types of musicians, or performers, I would say it's more types of people. So any person could experience any of these types, or any of these mechanisms could be relevant. And also, just to be very clear, it's very rare that one of these mechanisms is the only thing going on. So most of our patients are presenting with a mix of these mechanisms. Sometimes some of these mechanisms happen to be more important or louder, if you will, for some of our patients. Regarding the types, so as Monique said, if we're thinking about that, if we know that neuropathic pain is commonly provoked by certain positions that either compress or stretch the nerve, certain musicians specifically may be more susceptible to certain nerve pathways becoming more irritable. Monique mentioned flautists. I felt like one day I was running a case series on neuropathic pain in flautists. I had 3 flautists come in the door during a walk-in clinic on the same day. All of them had signs consistent with sort of thoracic outlets and ulnar-sided nerve pain. Okay. And when I think about that position, the combination of that position with their right arm being in shoulder abduction, external rotation, their hand being in a bit of radial deviation, and then having to finger the instrument with their neck turned away, breathing a whole lot, that kind of made sense with that stress down the pathway. Now, that being said, one of those patients, their nerve provocative tests were relatively mild, and their first rib was super stiff, and they also had some muscle stuff, so they looked a little bit more nociceptive with some neuropathic components. The second person looked very neuropathic. As soon as you brought her into an ulnar nerve test, that lit her symptoms up. She responded remarkably well to treatment along the pathway, which I think we're going to get to. And she found that doing ulnar nerve slides were remarkably beneficial for her and really important for her to do as a part of her warm-up and in her breaks during practice. The third patient was really, you take all those pain mechanisms we talk about, mix them all up. She definitely had neuropathic component, but she was also someone who had more cognitive affective tendencies. She had diagnoses of depression and anxiety. She had significant tendencies towards catastrophizing. Um, she did not have a great relationship with her studio instructor. She had other things going on in her life. So she had these other components that were ramping up her entire pain system. And so her nociplastic components were also much more important for her than they were for any of the two other individuals. So things to think about as far as, so I think any person could present with neuropathic pain. I think it's some of those other factors about how are they doing to manage things, and maybe, we do know that there may be some genetics that might predispose someone to having different pain phenotypes. A lot of the psychosocial factors are relevant for pain in general, and particularly might be amplifying that nociplastic component.
Any thoughts, Monique or Andrew, on this topic?
I agree with Mike with everything that he said. The one thing I was going to add, Mike, I don't know if it's worth sharing. There was a study from Colorado that recently was updated, I think this year. And actually, I don't know if I can share my screen. Let's see.
I can drop the reference in the chat.
Okay, yeah, he'll drop the reference in the chat. But basically they looked at peripheral neuropathic conditions associated with various instruments, and found certain kind of patterns, if you will. And so I'm trying to, let me pull this up. Slideshow. Although I don't think it's gonna let me do that. I'll just talk through it. So you can look at the slide and see, but basically carpal tunnel syndrome was associated with keyboard and strings. Ulnar neuropathy at the elbow was with the strings. Thoracic outlet syndrome was strings, brass, and woodwind. Posterior interosseous neuropathy, or the radial nerve, was with strings. Median nerve and the anterior interosseous neuropathy, strings. Digital neuropathy, flute and percussion, and then cranial facial neuropathy was brass. So that's where I was talking about earlier, of thinking about what is their actual positioning, right? So it makes sense that brass is more facial because they're blowing into the brass, they're putting strain in those structures. Similar with like strings or flautist, right? As in those positions, those more asymmetrical kind of positions, they're putting more tension on the nerve naturally just when they have to play. So that is just another consideration as well. Doesn't necessarily mean that it's going to be worse, as he mentioned, right? There's a lot of kind of psychosocial factors that play into it. You could be the same, you could play the same instrument and have completely different responses with the pain, but that's just something to consider.
Yeah, I didn't have anything else. I was going to mention we had that study, so you did. That's perfect.
I think that serves as a nice transition to discussing how not necessarily the professionals, performers, but in the younger population, or even let's say the recreational population of performers, how does the presence of pain influence pain inhibition during exercise? Or are there trends you've observed in how that perceived severity or the severity is impacting their pain inhibition and ability to complete exercise?
I think, I mean, with pain inhibition, it would be common with anyone who has pain, as it's likely to change performance. When we have pain, we move differently, and some of that is to either avoid pain or to change the load and stressors that we have, and some of it can also be habitual over time if we're talking about the nociplastic population. I think as far as considerations for younger folks, I would say one of the things that I have seen is that when you're dealing with, I don't treat young, super young, but when talking about maybe teenagers or preteens, some of the differences can also be in how you dose things like home exercise programs. I have found that the teenagers are a little less compliant. They need a little bit more push from the parents. So it may be a little bit different in terms of how you approach, how often you may have them come into the clinic. So there may be some some differences there. Also, if I tend to see folks that are a bit younger having issues, I'm also a little bit suspecting and a little bit curious to see if they have any hypermobility, because here they are coming in at a fairly young age and already reporting symptoms that, you know, may be something that would manifest a little bit later, but more often than not, they may have really high Batten scores or have already been worked up for a combination of things like hypermobility and POTS and some other stuff. So if I'm seeing some younger folks coming in with some issues, that could be a consideration as well. The other consideration I thought up was a case that I had. This was a fiddle player from Western Maryland, and this is a fairly rural area. They had instruction and they had teachers along the way, but for whatever reason, the way that he learned to play was not ideal. He had a lot of extension in his wrist on the fingerboard side, and it was leading to some development, even at the age of like 14, of some carpal tunnel-like symptoms. And so that was a very technique-based thing. And he had even said, like, oh yeah, my teacher said I shouldn't do that, but you know, I didn't feel like listening to it. So he didn't. And his issue, he was a great example of somebody who was hard to change because he was young and he was playing with professional bluegrass players. And so he had to play fast and he had to play accurately. So going back and changing your positioning at the fingerboard is really tough if you have to play at that level. So that was a challenge for sure. So that was a training thing. But again, he came in real early, and there was a combination of technique and also how much he was playing as a young person. So I would say those are kind of some of the considerations: the dosage of exercise, training errors early on, and potentially some other comorbidities like hypermobility or POTS.
Yeah,
Great.
I would,
Sorry, go ahead.
I would also add, I think aside from all of those things with the younger population, it's important for everyone, but especially with the younger population, if there may, aside from neuropathic pain, there could be more some of that nocioplastic pain if they're really fear avoidant of things. And so I think that's another time to consider like pain science education as well, and being aware of kind of your language, especially with a young kid, because you know, we said the general population hears nerve and might get worried, but especially like a young kid, they hear nerve, and that sounds very scary, I would say, to a younger performer. So just being aware of that and providing appropriate pain education that way, and which may also lead into practice habits as well, and giving recommendations for that as well.
Great segue, Monique. So now let's talk about what standardized pain assessment tools you use in our performing arts population.
So one thing we can do is we can go back to those 3 slides and just keep those concepts in mind. Particularly those those differences in the subjective exam can be remarkably important in helping you begin to recognize that maybe neuropathic or neurogenic components are relevant, and to make sure that you're including that in your physical exam. If we think about questionnaires, because those are standardized, so there's the quick dash, the performing arts specific component of that, which is not specific to neuropathic pain, but can be something that helps capture their disability. I also personally just like a patient-specific functional scale, as far as because those patient-specific functional scales can help you really dial down into what components of performance are relevant for a patient and help you develop a good connection. So not just I have difficulty playing violin, but I have particular difficulty playing arpeggios high up the neck, may start to cue you into things. I've already mentioned, as far as other questionnaires to recognize pain mechanisms, the central sensitization inventory is really intended to investigate or tease out the sort of central sensitization or nociplastic pain components. So people can Google that, but it has lots of great questions that are really pretty widespread to capture those concepts. More specific to neuropathic pain, there are two questionnaires that are out there that I'm familiar with. The Leeds Assessment of Neuropathic Signs and Symptoms Scale. And then I got to pull the other one up here. Hold on. It's the DN4, which is which was originally French. I will not insult anyone with my 7th grade French. So the DN4 questionnaire is also a questionnaire designed to tease out neuropathic pain. Both of these scales are very similar. They both have a significant component from the subjective exam, and they are asking things like, where is your pain? Is it prickly, tingly, and that sort of thing, for example. The Leeds assessment scale asks also, like, do you have skin changes, mottling, redness, that sort of thing? And they also ask about abnormal sensitivity to touch, so hyperalgesia and or allodynia. They also ask about sort of the random bursts of pain, which is not common in nociceptive pain, but can be common in both neuropathic pain and nociplastic pain. Do they ask about temperature changes? And then there are some physical exam procedures. And the DN4 is very, very similar. So if people aren't familiar, I think we can, I see that some Physiopedia, we're not, by the way, endorsing any particular source here, but Physiopedia is cheap and readily available on Google. So there, we've dropped some links there for you.
Yeah, make sure you check the chat for those assessment tools. Laura was dropping in the tools as Mike talked about them.
The only one that I would add for nociplastic specific that's really useful is called the Ospro Y, which is a combinational tool that combines a number of different targeting sort of psychosocial issues tools and puts them all together. And what's nice about it is you can use the Ospro Y score to get a score of any of those other ones. So if you want the Tampa Kinesiophobia scale, you can correlate the Ospro Y score to that one or any of the other ones that they use. And what's nice is they break it down into categories. So some people may be more fear avoidant, some people may have more catastrophizing behavior, and it can help break it down. It's free online. You can get like a little calculator sheet as well too. So there's just another one.
Can you please spell that for Laurel to pull it up? Do you have the spell? Okay, thank you.
I
Perfect.
believe that's what it is.
Okay.
Yeah.
Great. And then continuing on in our assessment, I know Monique brought this up at the beginning. Can you speak to the hypermobility aspect of assessment? I know Monique mentioned ensuring you're taking your patients to their end range, not just stopping by the textbook version of an, especially like upper limb neurodynamic test. How can hypermobility influence the way you're assessing? And then also, what kind of modifications are you giving to a nerve glide exercise?
So the assessment we kind of I chatted about before, right? So making sure you go into the full range. And then I would just say in terms of treatment, you're using that range to do, right? So let's say you give them a nerve glide or a nerve tensioner, that's gonna be based on their irritability level, right? So if they're really, really irritable, I'm not gonna immediately tension them and just flare them up. I'm gonna start more with a gentle glide where, you know, they might have their head moving with the hand so that you're giving slack on one end while you're giving tension on the other. And that's something that's gonna be applied to anyone, right, in terms of dosage of how we're managing irritability. But I think the biggest thing with the hypermobile patient is that you're working within the ranges that they need to do or are causing those symptoms. At the same time, you don't want to encourage someone with hypermobility to be locking out their joints repeatedly, right? But if that's what they have to do to play their instrument, then making sure that you're capturing the demands that they're going to be performing. If they're able to modify, I think in terms of playing, then potentially that's another avenue you could go down. But as Andrew mentioned, right, if this is someone that's been doing this for a really long time, that might be a little more challenging. So that's where I think treating the range that they are going to be using is a nice way to progress them.
Yeah, I would mention that it's also important to kind of consider whether we're talking about more generalized hypermobility or more localized hypermobility. So is this something that has sort of repetitive motion that's created it? Or is this something that is more like EDS, Ehlers-Danlos syndrome? And so we're seeing more congenital hypermobility. And for those folks, the consideration may be exercise dosage. The tendency for those folks is to respond better to lower loads but higher repetitions. So that's another one of those considerations. So considering, do we have excess motion at one joint that's a problem, or is this more of a connective tissue disorder problem that can be helpful to differentiate?
Yeah. And then one thing I would add is just helping patients understand that, we think from an exercise point of view, we think primarily of tensioners and sliders or gliders to calm things down, and then tensioners to improve someone's resiliency when they are less irritable. One of the things that I've seen that's important is that because any person's irritability may fluctuate day to day, hour to hour, week to week, is that the person may need to understand how to best modulate their exercise to match their current irritability. The tensioner that they did yesterday may not be the appropriate thing for them to do today after a 3.5-hour rehearsal when they're super flared up. So helping patients just understand, it's the same movement, but I'm doing this at different intensities based on my current symptoms.
I think that's a great clarification. I was going to ask as a follow-up, how do you put into the equation, is it a performance day or a rehearsal day? And can you talk through a little bit really what that dosing conversation looks like with your patient?
I'll start here. I do like neuromobility exercises as part of a warm-up. Personally, I'm a string player. I find them personally helpful. I see that a lot with the people that I work with. Again, whether they're musicians, dancers, or just other regular humans. I think that during practice, I also encourage people to use them frequently throughout a practice session to help calm them down. So, and this gets part to their playing habits. So, I like my patients to understand, hey, I have easy practice, hard, medium practice, and hard practice. They might need to think about how much they're doing of each of those. That's a different conversation. But then, and so that they're breaking that up. But then, hey, maybe you're doing a small dose of difficult practice, and don't let that hard practice really flare you up. Don't do it for too long, because the more flared up you are, the harder it is to calm you down. So do a smaller but more frequent dose. And then ideally, if you're dosing sliders correctly, they are oftentimes pain relieving. So they're a good thing that can be done in the middle of a practice session. And also after practice sessions to calm them down.
Yeah, I'll just add that I do teach a lot of self-massage along the path of the nerve. So to complement the sliders. So the way I tend to think about treatment is the way that Michael Shacklock thinks about treatment. He's a researcher in neuropathic pain and neurodynamics out of Australia. And he thinks about it like treating the container, which is sort of the path of the nerve, and then the neurodynamics, meaning the glides and slides themselves as two components. And so I'll do that, of course, with patients when I'm with them, but I'll teach them how to massage certain areas. And especially after performances, we're thinking almost like recovery for an athlete. How do we help an athlete recover from a game? right? So your strategies there may look different if it's a big, concert after concert after concert versus this is the sort of they have some downtime. Similar to an off-season athlete versus an athlete in the playoffs, your considerations for what you're doing. So one, I may be trying to facilitate recovery versus the other, I may be trying to actually make some changes over time to different things.
Great point. And then I'm going off script with this question, but I feel like it's a good follow-up. In dosing these kind of things, which can contribute to some irritability, do you have a preferred self-assessment, self-reflection tool that you'll use relative to neuropathic pain, like the traffic light, or is it just something you use more of your individual education, patient
I've
education?
I've used like the traffic light analogy before of being like, you can pick a pain threshold of being like, okay, let's say you're at kind of just basic pain rules, right? Let's say your pain is a 5 out of 10. You do a couple of these glides. I think the big thing is educating them of how far to go in the range, right? Because I think a lot of people are like, oh, tension, like glides, whatever. And then they're just going too far and then they're just lighting things up. So I usually tell people like, it's like a little kid like learning their boundaries, like you're going just to the edge of like where that comes on and then you're backing away to the edge, back away. And then I'll tell people like, as you do this, it should improve. Like you should A, start feeling better, or B, start feeling like you can go a little further in that range before those symptoms are brought on. And then I usually will tell them if you're doing it and it's increasing your pain from, let's say, that 5 to a 7, like that 2-point increase, that's too much to back off. I'd rather you stop than just pushing through mindlessly and flaring things up. So again, just that education piece. And you can use just basic pain rules of if you're getting a big spike, we need to back off.
Yeah, that's perfect. The one thing I will add is with folks with chronic pain, if there's no C-plastic components, sometimes they won't necessarily tell that they're going too far in the moment. They'll have delayed symptoms. It's very common. It's a latent effect. And for that, what I'd like to use is kind of what, again, with back to the athletes, is RPE scales, rate of perceived exertions, because you may not be able to tell how much pain that you're in, but you may be able to say how tough were the activities or the combination of activities that I did during that day. And then I had this response. So they may be able to consistently be able to say, okay, my RPEs at this level result in this type of response later on. Because that's frustrating for patients. They'll say, I felt really good, I felt great, and then the next day I could barely move. And so having a way to anchor it with maybe exertion as opposed to pain, which can be very fluctuating, can be a nice little anchor as well when there isn't a way to tell the traffic light until you've already blasted through red and you've gotten a ticket.
That's a great, insightful analogy. I think that's very helpful. Mike, anything else to add or keep moving on with our?
Yeah, I would keep moving on. Yeah.
Okay, then we have spoken to this in musicians, but there was a question about, are there common technical faults or training errors that predispose dancers to nerve-related issues? I know we talked about the fiddler. That was a great example that Andrew gave, going into that like hyperextended position of the wrist, but can anybody comment on more specifics to dancers?
Yeah. So I can jump in for this. So right now I actually have like 4, maybe 5 younger dancers. As we know, dancers tend to have injuries more in the lower extremity compared to musicians in the upper extremity. So I think one area that I see a lot is like hamstring strains, right? Or even I have a few patients with like partial hamstring tears even. And I think that it's important not to forget about the sciatic nerve along with the hamstring, right? So we know how to do eccentrics, that sort of thing for the actual like muscle strain. But oftentimes there is a sciatic neuropathic pain associated with that. And a lot of times doing nerve glides for the sciatic nerve has made a drastic improvement for flexibility and returning dancers back to their sport after like a hamstring injury. So that's usually like when I treat any dancer with a hamstring issue, I test doing like a slump test or straight leg raise test, and seeing like with the head positioning if that changes their symptoms, because if it does, then you know there is likely some kind of neural component aside just from the muscle itself.
And then continuing on the dancer line, there was a question about if there are any preventative strategies that could be communicated or recommended to dancers and instructors to minimize risk of neuropathic injuries.
I think this goes for both groups, but that highlighting the importance of a dynamic warm up, right? To making sure that they are preparing their body. So muscles like blood flow, they like oxygen, they like space. They don't like to be stretched. So similar to what Andrew was saying in terms of like treating along the container, right? If their muscles are already really tight along the way or myofascial tissue, whatever, if the nerve can't move through that container as well, then they could be more susceptible to those type of injuries. So not only warming up the muscle, but warming up all of the tissues in those dynamic movements, not just going into your splits right away, right? Like you have to do that warm up. I think also strengthening to control the range, right? Because dancers are going through really extreme ranges of motion to make sure they're, you know, for example, with the hamstring, right? A lot of dancers tend to lock out and kind of sit into the back of their knee. So they're not really using their muscles to support them, which then may be putting extra tension and stress on some of those passive structures that aren't supposed to be stressed, which the nerves are going to fall into that category. So.
Thank you. And I know there was questions relating to aerialists as well. And I think just for the sake of time, we're going to stick with the dancers and musicians. In this section, Andrew, if you have a reference for the container idea, I think that would be helpful to throw into the chat. And then with the time that we have remaining, I'd like to open it up to the panelists. If you have a challenging case or a unique case that you'd like to share, maybe run through those, and then if we have a little bit of time left, we can kind of open up to any remaining questions.
About the container idea, I have a few slides on it. We don't have to put it up, but I can send it, and so anyone can access the slides. A lot of it's the path of the nerve, so you can use anatomy to guide your path of the nerve. And I have a couple of pictures and a couple ideas on that, but I can always send that to you guys.
That would be great. And we can always send that out when we do the send of like the recorded link. So I think if you forward those to myself or we can share those out, that'd be fabulous. Thank you.
I'm going to drop a randomized trial investigating soft tissue mobilization in upper extremity neuropathic pain. I'll drop the PDF in.
Great.
Give me a second. But happy to address other questions while I'm finding this.
Or did anybody else have a unique case? I know Andrew, I think the young fiddler was a great case. Any other contributions?
I don't have a specific case in mind, but I was also going to mention just in terms of references and tools. The three of us did present a poster at PAMA on this topic, and we actually have some QR codes with some videos that might be helpful just in terms of like upper limb tension testing, nerve glides, nerve tensioners, and also doing some of that soft tissue stuff along the pathway. So we can try to, I can send you the QR codes with all of those videos.
Wonderful. And then at this time, if there are any audience members that had a question, I think we have a little bit of time left just for questions and then closing comments.
We don't have a question. I'll actually talk about a dancer.
I think it's you, Mike. Go right ahead.
All right. This is a dancer I treated a little while ago, collegiate dancer who had come in at the beginning of the fall semester coming in. And at the beginning of the fall semester, she decided to audition for the major dance show. So had to demonstrate jazz, ballet, tap, modern, all in a relatively short window after a relative period of downtime for her. So that's one thing that's important, relative. That's very important. So for those of you who might be thinking about like acute to chronic workload ratios, that was very different. She presented primarily with pain along the dorsal edge of her foot, dorsal side of her foot, and then into her great toe. Some of the nature of her pain is what clued me into that there was a neuropathic component. So she certainly described that her foot felt very stiff, weak, and achy, but then she also started using language of like, it's kind of tingly, it's burny. I feel like if I go in this certain direction, I get shocks. I had asked her a bit about like the footwear that she was wearing, and so some of those auditions were barefoot, but she did happen to demonstrate some some of the footwear were straps right across the dorsal edge of her foot, right where the dorsal interosseous nerve kind of comes and runs right next to the extensor hallucis muscles. And so she was tender to palpation locally there that reproduced radiating pain down into her big toe. A sort of run-of-the-mill straight leg raise or slump test were not particularly provocative, but if you preloaded her foot into plantar flexion and inversion, and particularly with great toe plantar flexion, and then took her into a straight leg raise or a slump test, that brought on her symptoms, and you could differentiate her symptoms. So for example, when the supine straight leg raise, I could differentiate her symptoms by abducting or adducting her hip, which I felt fairly confident was not changing any tension in the tendons in her foot or the joints in her foot, for example. The location of her symptoms happened to match right where one of the straps for her shoes crossed the top of her foot. So everything honestly lined up relatively nicely. We taught her some specific nerve glides, emphasizing that movement at the end of the foot. And then if that was more irritable for her, we taught her to emphasize movements that were more proximal, so knee, hip, and spine. So she didn't have to move the foot itself. And then did a little bit of taping to just support her foot and some soft tissue along the pathway, and she made progress very quickly.
Great case example. Thanks for sharing that, Mike. I know we're just about at the top of the hour. I would like to take a moment to give a special thank you to our presenters today, our panelists. I think this was a very informative and interesting session. I'm going to hand over the mic in the last minute to our PASIG president, Laurel Abruzzese, who just has a few comments to make. But otherwise, thank you everyone for your attendance and your participation.
I just want to extend my thank you as well to Mike, Andrew, and Monique, and to Melissa for organizing this panel and for being our moderator tonight. This was really wonderful. We love to engage our members whenever possible with our citation blast, with our podcasts and programming at CSM. If you haven't registered for CSM, please do so. We hope to meet you in person. And our meeting will be on Thursday, February 12th from 4 to 5 p.m. Usually they stick us at 6:30 in the morning and it's a small group, but we're going to turn this into a little gathering and social event as well as a meeting. So stay tuned for more. If you're not a PASIG member and you learned about this through a friend, join APTA Orthopedics, and then the SIG membership is free, and Orthopedics is free to all students. Again, thank you. This was a wonderful panel, and thank you for all who were able to show up tonight, or early evening for the West Coasters. Thanks, everyone.
Thank you.
Thanks, Tara, for recording and helping with the logistics and marketing. you.